what about trigeminal neuralgia? Everybody sort of knows about this one, but orofacial pain dentists can treat this and are treating this. And we have referrals all the time for the management, medical management, usually. And we also work with neurosurgeons who have other surgical ideas if, in fact, medicines aren't working. But so I have this little lady right here to show, because many dentists, and I don't know exactly the population we're talking to right now, but many dentists hear about this but have not seen this. So here's a lady with trigeminal neuralgia.
It's blowing frequently.
Okay. And when this episode hits you, it's a very, very severe pain. Right?
Yes.
So if we ask the question, 0 is no pain, 10 is the worst possible pain ever, what would you rate it as?
10.
Okay. Now, in between your pain episodes, we have an episode right there. Going away now? Okay.
Okay. You know, this experience, when you look at this, it's pretty simple to understand. This is not a dental problem. This is some other problem. Now, the stats will show us, though, that when someone shows up with trigeminal neuralgia, almost always dental procedures have been done first, which have nothing to do with this pain condition. So now we have with orofacial pain a specialty that we can send patients to, and they can be managed this way, like the neurologist would manage, et cetera, like that. And this patient can be medically managed. And this patient was well under control once we started her on the right medications. We have also neuropathic kinds of conditions. Some of these things are neuritises. Okay, so what do we mean by neuritises? What about acute seventh nerve neuritis, which brings about Bell's palsy? So now he can raise his eyebrow on one side, but not on the other side. He can close his eye tightly on one side, but not the other side. If he smiles, this side's not functioning. So the seventh nerve, the nerve involved with facial expression, has been involved with a neuritic condition, probably a viral infection like this. So these are patients that we have a chance to see. Many of these don't have pain because the seventh nerve doesn't have nociceptive quality. Some do. Therefore, the trigeminal system's involved. And when the trigeminal system's involved, you can get acute herpes zoster. So this is shingles in the face here. Typically, shingles are felt in the trunk, but it can be in the face. And here it is. And this is the ramifications of what's happened to this patient with an acute exacerbation of herpes zoster. We can manage that in orofacial pain areas. This is what happened to this patient earlier on. Ophthalmic branch got vesicles. Now they're scars. But unfortunately, she's developed what we call post-herpetic neuralgia, a very difficult central mediated type of neuropathic pain condition. Orofacial pain dentists know how to manage this on a pharmacological standpoint. Over here, we have some of the peripheral things that will bring some persistent neuropathic pain, tumors and such. And at least orofacial pain can identify these things. And maybe these are surgical options that are there. And maybe the orofacial pain surgery is not going to do the surgery, but identifying some of the lesions, cancer is some of the lesions, cysts and such. There's central mediated. Now we're understanding more about central mediated pain conditions. And so I want to share this patient with you about what we're seeing a fair bit of, toothache of non-dental origin.
Okay, now you're having some pain on that lower right side, is that right?
Yes.
And how long has that pain been going on?
For about 4 years.
4 years of pain, a toothache. Show me someone who's had 4 years of pain and the toothache is really an infection or a tooth problem, odontogenic problem? No. But here's what happened to the lady.
Had to be pulled, and I had to have an implant. Then about a year later, the tooth behind that, they said, was causing the jaw pain, and they extracted the tooth. And when they did, they said the tooth was perfectly healthy, but once it was gone, I had to have an implant there. And then this past December, the tooth on the other side of the first implant, they said was causing the jaw pain, so they did a root canal. And at that point, the endodontist and the dentist said, we don't want to do anything else to you until we find out what's causing this pain. And that's what brought me here.
So we see a reasonable number of patients that have these experiences where they continue to have pain felt in the region of a tooth, even though it was extracted. implant placed, multiple. This lady's been through multiple extractions and no resolving pain. This is what orofacial pain dentists can treat and manage. What about oral mandibular dystonias? Over my years, I've made some very interesting patients. This is a dystonia where there's a unilateral left inferior lateral pterygoid dystonia. Pull the jaw to that side. Associated with pain, sometimes not. Dystonia. These are conditions that orofacial pain dentists can treat. Here's a jaw closing decision.
Okay. Yeah, there we are going right now. So we have a closing oral mandibular dystonia, and the muscles uncontrollably will tap the teeth together. And tell me about how long that's been going on.
It's been about a year, at least a year.
Okay.
So she's biting her cheeks, biting. Does she have pain? She has just fatigue. It's not painful. This lady I've been treating with Botox about every 3 months or so because dystonias have a central mechanism and the Botox will help for that. I just saw her 2 days ago, in fact, and it's been now usually about every 3 months, and now she's at about every 4 or 5 months. So dystonia are things that can treat. There's some unique ones, like this is a lingual dystonia.
There you go. And let me ask you again, how long have you had this going on?
About 2 years, a little over maybe.
And it doesn't interfere too much with the speech. But it's pushing your lip like that and cheek. And does it actually?
So what we're looking at here, 2 years, this lady's had her tongue moving like this. You know, she has no place to go. We need more orofacial pain dentists who understand this condition, who can offer the correct care for this. And we have care that can make a difference for these patients. So there's a whole group of patients out there that the dental profession doesn't recognize as patients that could be really helped by an orofacial pain specialty and the training of those. So how do you get this training? All right. Well, you know, we started our clinic in 1977, but this is a clinic that just spends time just dealing with pain. So we're doing very little, if any, dentistry. We make appliances on occasion, things like that. So what we've learned here now is that there is a bona fide 2-year certificate program, which the American Academy of Orofacial Pain began, got it to the Commission of Dental Accreditation. Now we have 13 programs this is my number right now as I looked at, 13 programs in the United States, which are the Commission on Dental Accreditation, CODA approved accreditation. Okay, so we have standards now, just like every specialty in dentistry, orthodontics, prosthodontics, endodontics, pediatric dentists, oral surgery, they have specialty training by the Commission on Dental Accreditation. So everyone has to teach the same types of things. They're usually in 2-year certificate programs. Many have master's degree. Sometimes it makes it a 3-year program, depending upon the program there. So this is the training that's going on that is well needed over the years. Why did the specialty take so long? Because early on, when we went to the commission, when we went to the American Dental Association, saying that we need a new specialty, they would say, wait, you don't need a new specialty. The prosthodontists treat TMJ, the oral surgeons treat TMJ, the orthodontists treat TMJ. But they don't treat the patients that we're seeing here at all. Now it's only been with 20 or 30 years of battling with the American Dental Association that people are starting to recognize this is a field that's special by itself. And we have a board. We started this board in 1996. It's a psychometrically determined board. It's a very, very strong board. And when the specialty was established, the American Board of Orofacial Pain was then accepted as the board for this new specialty. And so we have a board. So when people who finish the certificate program can go to the board and be board certified, just like every other specialty that we have in dentistry. So, and let's just talk just a minute about the importance of a multidisciplinary care. What other specialists do you need? The concept we need to appreciate is that pain crosses all over all of the healthcare disciplines. Pain is not unique to dentistry. It's not unique to each medical field too. Neurology and rehab medicine, it's not unique to that. It crosses over all these barriers like that. So we need to appreciate when it does, so that we've got to understand that other medical healthcare specialties are also treating pain. What is it they do that we can do? What is it we do? What I've learned in this field is when you look at medicine has very little appreciation for what orofacial pain is about. Now, as over the years, we've got a whole network of 15 different physicians and medical specialists that teach our residents. They understand more, and we see referrals back and forth because we understand what their other healthcare providers can provide their patients. We look at lesions like this that produce pain, and so we have oral medicine that's part of dentistry that can be helpful in this. We have oral pathology. We're understanding whether these are aggressive lesions or self-limiting lesions. We've got oral surgeons that help with some of these pain conditions. So there's a multidisciplinary team there within our field of dentistry that can be really useful. What about psychology? Well, if we go back to the classification that I showed you before, all of these conditions here are the physical conditions that present pain. But over here, we have what we call axis 2, which are psychological conditions. And so the conditions over here need to be appreciated by dentistry, that these are individuals that may benefit from different types of psychological therapy. Now, this is really true when it comes chronic. So when we start seeing patients having chronic pain conditions, then we start to see the level of depression, level of anxiety, level of anger, frustration, all become great, as they would for all of us. These are not conditions that cause the pain. This is what the pain has caused in our patients. And we need to know, we need to be able to understand that relationship. We need to teach our patients how they can gain some control of pain. So in our program with our psychology, we have a psychologist and 2 or 3 psychology residents. We teach people how that they can control their pain. I tell patients, Mrs. Smith, we need to teach you how to control your pain from the inside out, because we dentists all work from the outside in. If we can help them quiet some of the central mechanisms, they can get better control of their pain. It may not stop the pain, depending on what the diagnosis in the axis 1 is, but it's ways that they can manage themselves and get a life back. By the time we meet the chronic pain patients, and our average patient has a little less than 4 years of pain before we get a chance to see them, their life has been destroyed. The quality of their life is zero. They've lost jobs and marriages and all their money, and all that contributes to the pain experience. So certainly psychology is important, but we also have to look at physical therapy. There are certain patients who can benefit greatly by physical therapy, especially if it's in the musculoskeletal category that we just talked about. What about neurology? Sure. What about neurosurgery? Sometimes, yes, depending on, like the patient with trigemorrhalgia, sometimes neurosurgery may be indicated. Rheumatology, internal medicine, rehab medicine, interventional pain management teams that are around medical centers that are dealing with other pain conditions, back, shoulder, neck, leg pain conditions. ENT needs to understand what it is, why they send patients. A lot of patients go to the ENTs, don't see disease, get them to the dentist. Maybe that's appropriate, maybe it's not appropriate. So what we need to appreciate is all of these are teams that can help us as orofacial pain dentists become better treating patients. Each of the orofacial pain programs that I just mentioned have different strengths. All of these things are not necessarily strengths in every program, but they're available and things need that way. So we look at all those programs as we try to educate our dentists into the field of orofacial pain. So how can a non-orofacial pain specialist learn more about orofacial pain diagnosis, provide initial treatments for patients with orofacial pain? Well, what you just heard already at the beginning of this whole series that we've putting together here is really being spearheaded by the American Academy of Orofacial Pain. The American Academy of Orofacial Pain is the oldest organization, really, that are dealing with it. It's the organization, and I'm biased, obviously, but it's the organization which is the most founded in science. And as we learn more about these conditions, we need to extend out there for our patients more and more help. But it needs to be evidence-based. It needs to be something that we can say that we've got evidences. And Dr. Klasser is going to talk about evidence-based, I think, on the third series that we're talking about here. So look at the American Academy of Orofacial Pain. This is the scientific session we have. Every year there's a scientific session. Look at all the speakers. All these speakers are there talking about pain in a 2 to 3 day session. You've already heard the fact that we're going to have a special session for some of the individuals just getting interested in pain. But there's also in 2023, at the same time, the American Academy of Orofacial Pain has the annual scientific sessions, May 4th through 7th. It's going to be down in Disney. People can go down there and bring their families, vacation, at the same time, get a better understanding maybe of what's going on in the field. And lots of these talks are cutting edge areas we're trying to figure out how that fits and why it fits. We also have the American Academy of Orofacial Pain guidelines. Anybody can get one of these guidelines and look to see what the different disorders are. What are the assessments? What does it take to make that diagnosis? And what's the management, which is evidence-based right now? The American Academy of Orofacial Pain and the sister academies of orofacial pain throughout the country, throughout the world, all came together many years ago and began this journal. Started as a journal of craniofacial pain, then it's turned to a journal of orofacial pain. Now it's a journal of orofacial pain and headaches. And so there's a journal out there specifically for this, where we see the science of orofacial pain. So, right, we are out there looking for answers. Our patients will come to us and they need help. And we need to make some judgment on not only what kind of pain condition they have, but what kind of management it should be. And we need to understand that we don't have all of the information necessary to help all the patients. I wish it were. We don't have that. But back to this, follow the man who is seeking truth, not the man who has found it. Seek out individuals who are working on the truth, not the ones that have already learned everything, because they may not have all the answers like that. And so we're seeking more and more. And every year we see little things showing up that helps us manage patients better. And we need to continue that.